Thank you, Jeff, for that very elegant and dynamically informed presentation of change. I want to talk about the process of recovery. I want to talk about the question, why does recovery take so long and why is it so difficult? I have to disclose all these things. I own a treatment center and I have spoken for lots of medications, so I guess that tells you I'm not anti-medication. I'm also a very proud member of Like-Minded Doctors, which is a group of physicians mostly in treatment and mostly in CSAM who are concerned that the direction of treatment is moving too far in the direction of the prescription of medication with neglect of psychosocial strategies. So to start, get us all on the same page, it's important to know that detoxification is not treatment for addiction. If all you do is detox somebody, you have not done them any favors. You have created somebody with addiction who doesn't have any drugs or alcohol or behaviors in them, but that's not treatment, it's a prerequisite for treatment. Addictionology is not a possible procedure. I'm sorry, addictionectomy is not a possible procedure. I know very, very many brilliant people who work in this field, and I have not known one person who works in this field to have ever performed an addictionectomy. Initial intense treatment should transition to less frequent and ongoing treatment as in any other chronic medical illness. And treatment is best concurrent with 12-step membership, attendance, and practice, or similar. If somebody is doing something that results in the same targeted, structured improvements that result from working 12 steps, then that will result in the same health and the same wellness. People and families change at depth in treatment and recovery, but they do that very, very slowly. And so we might want to ask why. Why is it true that this takes so long? Why is it true that it's so involved? Why can't you just stop using? Why can't you just stop drinking and things will get better? Well, there's several reasons, and I've divided them into 4 important categories. One is that there's a genetic predisposition. 48 to 66% of variance in alcohol dependence, for instance, is heritable. What does that mean? It probably means that there are a lot of people with the same experiences that predict addiction that don't get addiction because they don't have the genetic predisposition. The things that are inherited are related to dopamine signaling, and that can be imaged in MRIs. We have all seen the pretty pictures with the red and blue and the differences between normal people and people with addiction. And the genetics also apply to process and behavioral addictions. So there has been significant research that has demonstrated that process and behavioral addictions have the same genetic predispositions, and they are associated with reward deficiency syndrome in many, many people. Some of the candidate genes, and I would love to say, it would be nice as a public speaker or speaker to patients to say, there's one gene, you got it or you don't got it, and if you have it, you can't ever drink, and if you don't have it, you can drink normally. But in reality, there's at least 5 and probably 10, maybe more, genetic distinctions, alleles of common genes that can predispose a person to develop addiction. And some people develop one of them, and some people develop all of them, and some people distribute on the bell-shaped curve like anything else biologic. But these are some of the more well-known candidate genes. And then trauma. Dr. Brady gave us a very elegant presentation yesterday about the influence of trauma on the development of addiction. And just to reiterate, early life adversity reduces stress reactivity and enhances impulsive behavior. Let me say that these statements are directly from the abstract of publications that I'll be happy to provide to you if you ask for the references. The type of trauma predicts future pathologic behavior. High rejection sensitivity and shame, which are the result of trauma, predict relapse. And childhood trauma is associated with decreased limbic gray matter and also associated with relapse. Again, all of this is documented in available publications. Next, we have adolescence. So we have somebody born with the genetics who experiences trauma and approaches adolescence. And some of the studies on adolescence have shown that delayed reward discounting, a measure of maturity, is caused by adolescent use of drugs and alcohol. Adolescence and emerging adulthood use is important to outcomes. So if somebody starts using in adolescence, then their outcome is predictably less likely to result in permanent recovery, and it'll be harder to get there. Adolescent stimulation of dopamine D2 alters maturation of goal-directed behaviors. That's a rat study, but you can't really do that in humans. And the use in adolescence actually delays brain maturation itself. And then there's neuroadaptation. That's what happens when you use a substance over and over and over again, and the changes that you can actually take pictures of. Addictive drugs remodel the brain's reward circuitry. Reward circuits are desensitized, causing decreased pleasure and motivation. Conditioned responses are strengthened, causing increased cravings and negative emotions when these cravings are not sated. So when somebody has been neuroadapted by the use of drugs, that is not only an example of conditioned response, but the conditioned response are strengthened by the whole circular process through the limbic system. Executive functions are weakened, leading to increased relapse. So that's what the literature says. That stuff's easy to find. You can find it in PubMed in a few minutes. So what do we have? Somebody's conceived. At the time of conception, that person is genetically predisposed to addiction. And that predisposition exists until they rotate off planet. So that person is a potential addict. And then parenting happens to them. Now, there are often and commonly examples of egregious parenting in the patients that I see. But it's also true that nobody has perfect parents, and everybody is traumatized in development. And so then, in childhood, you have a traumatized potential addict. And if that traumatized potential addict begins to use drugs or alcohol during adolescence, then adolescence stops. There's an arrest of development in adolescence, and then you have an immature traumatized potential addict who, if that person continues to use regularly, becomes a neuroadapted, immature, traumatized addict. So this is starting to expand on why it takes so long and why it's so difficult to get well from addiction. The problem is that much of payment for the treatment of addiction only funds treatment for neuroadaptation. The treatment for trauma and developmental arrest takes a long time, and it takes a commitment to change at depth, or at least it takes a willingness to change at depth. And the acute care model of treatment is persistent. And relapse is often seen as a failure of treatment or a failure of the patient. So let's talk about these a little bit more. Neuroadaptation occurs in the brain. The altered brain thinks, believes, feels, and directs behavior in an altered way. You guys know what this is. You know how to recognize it. You know when this sits down in front of you. It is a patient who has stinking thinking. It is a patient who is self-absorbed and has an external locus of control, a loss of empathy, and a loss of spiritual connectedness. This is so ubiquitous and so unique to addiction that it is the direct result, it is the behavioral result of neuroadaptation that happens in the limbic system. It resolves slowly in abstinence. It resolves slowly in abstinence, and it's a predictor of relapse. That's why there is so much relapse in the first few months of treatment and recovery. And it resolves in the context of abstinence supported by recovery, and medications are often helpful. An example is neuroadaptation is a non-problem in an opiate addict if you give them a maintenance medication. So neuroadaptation stops being a part of the picture. We don't have medications that we can use, at least not successfully, for addiction to substances and other classes of drugs. And then immaturity. As I mentioned, when somebody starts using in adolescence, the maturation, the development stops. Now, you guys are a lot closer to adolescence than I am, but you remember adolescence as a horrible, painful process of learning how to feel bad and learning how to feel good successfully. And how to deal with hurt and disappointment, fear, rejection, and success. Those are the things that adolescence is for. Those are the things that happen in adolescence. And if somebody uses during adolescence, those things don't happen. Persons with addiction don't navigate adolescence. They modify feelings when they don't like them with alcohol or drugs. They remain stuck at the age they are when they start using or drinking addictively and they don't mature. In recovery or in abstinence, when normal feelings that are supposed to have been learned in adolescence, learned how to deal with in adolescence, when they happen, there's no skill there, there's no resource there. And so fear, hurt, rejection, and success all will predict relapse. And then developmental trauma. As I mentioned, everybody is traumatized by development, some more so than others. But in the face of trauma, defense mechanisms develop. Some people get cute, some people get funny, some people hide, some people become intellectual, some people get good grades, some people act out. And these defense mechanisms are effective for the child that develops them at the time that they're developed. But they are useless or detrimental or self-defeating in adulthood. During adolescence, most people modify these. Most people learn how it's not appropriate to express anger violently. Most people learn how it's not appropriate to be cute when you're at a funeral. Most people learn how to modify these behaviors, but people with addiction don't. And so when these defense mechanisms emerge in recovery, these defense mechanisms themselves will predict addiction or predict relapse. And then there's a genetic predisposition. Disorders related to this genetic complex include dependence on carbohydrates, gambling, religion, sex, aggression, intolerance to stress, certain personality disorders, ADHD, and novelty seeking. That's my favorite one, is novelty seeking. Many people in recovery, many people with addiction will describe the committee in my brain or the committee in my mind. And that is part of that genetic predisposition. There's evidence for reward enhancement syndrome, evidence for reward deficiency syndrome. All known predictive gene candidates involved in impact on the dopamine system. Most have a significance in interpersonal relationships. So if you're one of those people with a committee in your mind and you're novelty seeking, the thing you have to do is learn how to embrace yourself as a person like that and be genuine with the people that you encounter, and encounter people that can accept you, and medications can help with some of that. So what can change? Response to trauma can change, and developmental emotional arrest can change. So what is recovery from this? I'll tell you, one of the most elegant sentences that I've ever read is this, that was developed by a group of addiction specialists who met at Betty Ford for a weekend. And it's a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship. And of course, citizenship is in the Hellenistic sense of the word. CSAM has developed a much more wordy and possibly more biologically significant definition of addiction that I won't read, but you can look it up on the CSAM website. It describes addiction as a biologic state rather than a list of behaviors. What is a research definition of recovery? Well, there are several papers that describe recovery that are in the literature, but this is one I thought fascinating. Leanne Kaskudis and a group developed a list of 200 questions that they sent to 9,000 people who agreed to talk to them, and asked those 9,000 people to ask which one of those 200, not questions, statements, belonged in a definition of recovery. And 90% of those 9,000 people endorsed just 34 of those statements. And those 34 statements can be divided into statements about authenticity, statements about emotional competence, statements about healthy relationships, about right sizing of ego and spirituality, as well as attention to neuroadaptation. I think that what's important is that attention to neuroadaptation is only 1/5 of the definition of recovery. So how do you get from addiction recovery? You address neuroadaptation, you achieve emotional competence, develop healthy relationships, learn right sizing of ego and spirituality, heal developmental trauma, and develop authenticity. I think develop authenticity is like the gold standard of somebody in recovery. So how do you get how do you get well from addiction? It's real easy. All you have to do is stop using and change everything about yourself. And often, longitudinal professional intervention is required. And you ask the question, what if you can't get past step 3? Now, those of you who reject 12-step recovery, you might ask the question differently. What if you can't get to the place where you're willing to change at depth? Well, that's a problem. And in the context of that problem, recurrent relapse is predicted. So the willingness or commitment to change at depth is a prerequisite for recovery. Thank you.